Welcome to the Society of Dermatology Physician Associates Dermcast Live. Today, we will have a special session with Dr. Brad Glick, a renowned board-certified dermatologist and dermatologic surgeon. Dr. Glick brings a wealth of experience from his clinical and academic practices in Margate and Wellington, Florida. Dr. Glick is a respected member of the Board of Directors of the American Academy of Dermatology, AAD, and serves on the medical board of the National Psoriasis Foundation. Today's session, sponsored by UCB, is titled Demand More with BIMZELX, Transformative Results for Managing Hidradenitis Suppurativa. Dr. Glick will be reviewing the latest clinical insights, practical applications, and transformative outcomes associated with BIMZELX, a groundbreaking treatment for managing HS.
Good evening, everyone, and thank you so much to the SDPA and also to UCB for having me here this evening. Thank you for the very kind introduction. Let's jump in and talk right away about BIMZELX, a revolutionary therapy. And, we know we received just a little bit over a year ago the use of this product in patients that are adults with moderate severe plaque psoriasis. And we'll talk in a couple of moments about the fact that why there was a little bit of delay of this product coming to our toolbox, that we now have it across multiple indications. And of course, now where we have desperately needed an agent like BIMZELX, it is FDA approved now for the management of adults with hidradenitis suppurativa. And you'll notice the word transformative here. Remember the A and the F in the word transformative. So let's go ahead and move forward. As you know, that I am here on behalf of UCB, and thank you once again to UCB for bringing, as was just said a couple of moments ago, a revolutionary product to market. This is a promotional talk. It is sponsored by UCB, and I, the speaker, am being compensated for delivering this presentation this evening. So HS, as you all know, and we used to call it acne inversa, but it can occur in a whole host of areas. Axillary being the most common in women, the inframammary region, in men and women in the groin, gluteal area, postauricular region, in the cervical region. We can even see it in the scalp in different presentations. A horrifically difficult to treat chronic inflammatory condition that is characterized by painful nodules in these sensitive areas. And we know that the physical manifestations of HS translate to patients reporting other signs and symptoms such as drainage, foul odor, tormenting pain, restricted range of motion. And I'll share with you the best example of this. I run clinical trials in my practice, as many of you know. And last week, a woman was a new potential candidate for a clinical trial. When I came into the room, she was standing upright, and I went to go shake her hand, which I did. And I then did what we typically do, is I said, well, please take a seat. And she said, I can't. And many of these patients have such challenges, particularly in the gluteal area, that they have such significant pain that it's difficult for them to sit. So it's phenomenal that we're now adding therapeutics to the toolbox, and our patients soon will be even more fortunate as they receive an agent like BIMZELX. So some of the physical manifestations that these patients suffer with on a day-to-day basis trigger psychosocial and functional impairment. We know this very well. There are specific HS symptoms, clearly pain, discharge, itch, foul odor, that I just talked about a couple of moments ago. Psychosocial impact, emotional distress, embarrassment, social isolation, of course. One thing that's not here is also in relationships, sexual ability. Impairment of activities of daily living. And as you see to the left here, this is an individual. She's 38 years old. She's been dealing with moderate HS and says, I have made career choices and avoided greater work responsibility just to accommodate my HS, because I cannot have others relying on my ability to be able to work. And so that's just another example of the fact that patients with this condition suffer. They have significant impact on their quality of life, particularly as the manifestations of this condition increase. And we know several things. About 15% of patients with HS have severe debilitating HS. It's almost unmanageable. And in general, only about a third of patients with HS at any point in time, even with at least up till now with some of the current therapeutics that we have, systemic antimicrobial therapies, local care, anti-androgenic agents, other biologic therapies like tumor necrosis factor inhibitors. There's a lot of dissatisfaction as we see from some current data here with the inability of current therapies to reduce pain, to improve quality of life, to be effective, and especially long-term, as we're going to talk about tonight with BIMZELX, where we have some long-lasting results. And, you know, the goals here is pain reduction is a goal, improvement of quality of life, the effectiveness, and I would add in long-lasting, avoiding the progression of disease, long-term safety coverage so that we know that there are not significant consequences of the drug long-term, and potentially avoidance of therapy. I think all of you know that there could not be a disease state where there is a need for more multidimensional therapy, combining different treatments, but to have something that can significantly reduce the inflammatory burden, the clinical appearance of these lesions, the significant pain associated with the condition, we are godsend for some of these patients. And the last comment here is that there's a significant unmet need that is demonstrated here in a commentary by one of our colleagues in our dermatology space. So one of the challenges with all the inflammatory diseases we treat that we know is, logically speaking, the earlier we treat, the better. But there could not be a more significant disease in the form of hidradenitis suppurativa where this shines so true. You see here very early disease onset, there's stability of the condition and an opportunity to reduce that inflammatory burden and potentially limit it from even early disease presentation, and then ultimately what we see in terms of the waxing and waning of disease, but the heightening of disease where we see in the different coloration here, the potential progression to not only the beginnings of functional impairment, where, for instance, in the axillary region, where patients start to get the early tunnels, draining tunnels, and even non-draining tunnels that may scar, and they have limitation with their range of motion. And then, of course, in late disease, we can see essentially irreversible damage and progression of disease. And we know that the average delay in diagnosis is somewhere between as minimal as 5 years and up to 9 years in these patients with HS, as we know from kindreds that were studied in Olmsted County, Minnesota, a number of years back, and that cohort continues to be studied. And halting progression of this disease is critical. And so to have an agent like BIMZELX, which is the first and only approved biologic to selectively target the overly expressed interleukin-17A and interleukin-17F cytokines in this condition, adults with moderate to severe hidradenitis suppurativa, is really unique and revolutionary. And again, you'll see a kind of a theme this evening because we have experience thus far with our ability to have used it over this past year and a month in the management of adult patients with moderate to severe plaque psoriasis. And of course, we know it's just approved recently for psoriatic arthritis and indications that I'll mention forthcoming. So what about HS? What do we know? We're still learning, that's for sure. We know that there is a role for inflammatory cytokines. There is some androgen influence. Where does it start? We know that Th1 and Th17 cytokines play a critical role. Probably we've learned more in the last 10 years that it appears to involve more so Th17 cytokines, specifically IL-17, IL-17A, and as we'll talk about tonight, IL-17A and F. But it begins with follicular blockage, an inflammatory burden, as we see in the center, with driving of inflammatory burden by inflammatory cytokines like Th1 and Th17 cytokines, and specifically IL-17A and IL-17F. And we'll say in a couple of moments that we see in the lesions of HS and even in the perilesional space and even in normal skin, an abundance of IL-17A, but almost 10 times more the amount of IL-17F in these clinical lesions that we've been able to demonstrate in biomarker studies and in biopsies of these patients. And you'll see from the middle out to the right as the disease progresses. And there's inflammatory burden in and around that follicle and that hair bulb. We start to see the destructive changes that can happen in these patients with chronic inflammation, damage to the skin, deep abscesses, nodules, sinus tracts, non-draining and draining tunnels, and ultimately irreversible damage. It just cannot be improved. Perhaps, pray tell, maybe with surgery. So we know that IL-17F is a key driver in HS. It's overexpressed and more prevalent than IL-17A by about 10 times. We can see that there are dimers AA, heterodimers AF, and IL-17FF. We know these play a significant role in driving the inflammation in hidradenitis suppurativa. Get a little bit ahead of myself, but we see much of the same here. And we've learned from in vitro studies, once again, that targeting all three of these IL-17 dimers is what appears to generate the significant inhibitory response when it comes to blunting IL-17 cytokines. And these dimers, particularly IL-17FF, may be that critical inflammatory dimer that drives the inflammatory burden in HS. Because one of the things that we know is that when you inhibit IL-17A, IL-17A will downregulate IL-17AA and AF, but not FF. Now, we don't know the clinical significance of this, but we have certainly learned this from some of the laboratory studies that I just referenced. BIMZELX, what does it do? How does it work? How does it impact this immune pathophysiology that I just referenced? Well, it blocks IL-17FF in addition to AF and AA, these homodimers and heterodimers that we just referenced. And it provides more inhibition, very much likely that we've seen previously with inhibition of IL-17 alone. And so we know it's just another representation of what we continue to learn, what we continue to see in terms of the impact of highly selected and targeted biologic therapies by inhibiting IL-17A and IL-17F at that IL-17AC receptor. So let's dig in a little deeper. Let's look at the indications for BIMZELX, these transformative results that I've just referenced. Over 40,000, close to 41,000 patients already treated with BIMZELX worldwide, 11 phase 3, 3B clinical trials across indications, more than 15 years of phase 3 and 3B clinical trial use across such indications. And of course now, as a godsend for our patients with HS needing more therapies in the toolbox, where we struggled for many years to be able to treat these patients. It is indicated for adults with moderate to severe hidradenitis suppurativa, also for adults with moderate to severe plaque psoriasis who are candidates for systemic or phototherapy. Also recently approved simultaneously psoriatic arthritis, non-radiographic axial spondyloarthritis, and also ankylosing spondylitis. And so where we had a therapy that had a little bit of a delay, not a little bit, but a couple of years to come to market, now it has 5 indications. And so for me, as someone caring for patients in general, to me, that speaks to the safety of the product when the FDA continues to approve the therapy across multiple indications. So let's talk about how we can raise the expectations for those of us who are providing care for patients with HS and also for the patients themselves, and see how we can transform their condition in a revolutionary manner. So here's the study design of the BHERD trials. Now they're identical trials, BHERD 1 and BHERD 2, and then the BHERD open label extension, or OLE. You can see the important dosing arm to see here is the 320 milligrams, which we're used to. So that's 2 160 milligram injections every 2 weeks. Now we know that it's every 4 weeks for psoriasis, over 16 weeks, and then every 8 weeks thereafter, or every 2 months. And here realizing that we probably have to saturate those receptors a little bit more in a deeper seated process like HS. It's every 2 weeks for the first 16 weeks and then monthly thereafter. And so we see placebo control, placebo comparison, and those in the placebo arm, as we see these two specific arms from these trials, then cross over to receive BIMZELX 320 milligrams every 2 weeks thereafter. And then, of course, we'll get into the open label extensions data. The primary endpoint is the hidradenitis clinical response score of 50. We'll talk about what that means in a couple of moments. But really, for one of the first times, we also started to raise the bar. We're going to look at these kind of numerical responses that are higher, with 75% improvement to the high score, as we like to call it. And then as you look out to the right, we're going to look at other exploratory endpoints, high score 50 in different stages along the clinical trial, but also endpoints for high score 75, 90, and even 100% clearance, which is close to 30% of the subjects in the clinical trials. We'll see in a couple of moments. Here's some of the breakdown of the individuals, the kind of bolded or highlighted areas that we're looking at here are the dosing regimens that are pertinent and, or what our approved dosing regimens are. And what I really want to point out is that there was a typical balance of those patients that have HS, some balance between the different ethnic groups, although as we see in many clinical trials, and since this is a condition that does disproportionately affect individuals of color, particularly Afro-American individuals, we could very likely do a little bit better in our clinical trial setups, but nevertheless, this is well representative of a population of HS patients. And what I really want to point out is the severity of these patients. And so when we say moderate to severe disease, we have almost, close to half of the subjects severe. Most of them were moderate, but not by much. And so take that into consideration when you look at the clinical trial data, because it impacts the numbers that we see. We're very used to seeing these high impact responses in other disease states, like in psoriasis, and these patients were really sick. And so for them to be able to turn around is a particularly high bar for a therapeutic. And we see some of the other prior biologic exposures, which was close to 20% of the subjects in the clinical trials. And remember, some in these trials, they're designed all very similarly for HS. If you were on a stable dose of antibiotic within 1 month or greater of the trial, you could stay on that. But for the most part, most of the patients, this was a monotherapy trial. And as we look at some of the data now, if antibiotics were required for rescue or other therapies, those individuals, though they may have remained in the trial, they were also considered non-responders. And we'll dig into that in just a moment. I think all of us in this esteemed group that is watching this evening understands what the high score is. This is just really more or less a schematic of what an individual looks like at baseline with Hurley 2 hidradenitis suppurativa. The high score is an assessment of the percentage reduction in the abscesses and inflammatory nodule counts. So that's the AN, those counts throughout the body. And remember, this condition is not just limited to the axillary region. We alluded to that before, inframammary, the inguinal region, the perineal region, the gluteal and perianal region as well too. But this just gives you a nice, kind of schema of what it looks like at baseline, what it might look like over time in the middle with the high score 50, and then really complete resolution of these inflammatory changes, these nodules, these abscesses, these non-draining and potentially draining tunnels, as you see all the way to the right. Now, clearly, the schematic does not necessarily indicate that there is resolution of things like post-inflammatory hyperpigmentation, which is, hopefully something that we will study in the future. As we see, even in the schematic, there is some lightening of the pigmentary disturbance that we see on this schematic of an individual with HS. So we see rapid results just as quickly as week 2 with BIMZELX in treatment of these adults with moderate to severe HS. So let's look at the data. Now, remember, we have a couple of different arms here in the clinical trial. And what we're seeing here in this observed cases, these are the high score 50 responses. So about 22% of patients achieved hidradenitis clinical response score 50 as early as week 2. And it increased profoundly from 22% up to just short of 60% at 59% at the end of 16 weeks, the benchmark for the trial. And we see these numeric separations, a 10% delta just within the first 2 weeks. So that's pretty quick. We expect that of IL-17 inhibitors in psoriasis, but in the more difficult to treat condition, such as hidradenitis suppurativa, this is profoundly effective and rapid through my lenses as well. We see a 20% delta numerically at week 4 and so on, where 59% of the subjects, as I just referenced, achieving high score 50 at the end of 16 weeks versus 36% in the placebo arm. Patients also experience rapid improvements in their worst skin pain, and we'll talk about pain and how to quantify that as we see in clinical trials. And, we do simple numeric rating scores for pain, just like we do for itch that many of us are used to, these 0 to 10 scales, so 11-point scales for measuring pain, very similar to like we do in itch. And these improvements in the reduction of pain are maintained through the control period, and we'll see that they're also maintained long-term. So what we see here is an actual, to the left, an individual from the clinical trial. The abscess nodule count at 1, draining tunnels at around 3, significant inflammatory burden. To the right, you see this 25-year-old male who's just an individual who is indeed suffering with HS. You see his weight, see the location of his hidradenitis suppurativa. He's taken BIMZELX, in the typical protocol every 2 weeks for the first 16 weeks, and then to an every 4-week dosing regimen. And, what he says is, besides the constant pain of his HS, every single day was a battle with stains and bandages. I could wear only dark colored clothes. Let's move forward. So you'll see at baseline, this is an example of someone from the clinical trial. And you're probably thinking to yourself, well, I see what I see to the left here. It's a limited area. In the clinical trial, these subjects had to have at least 2 areas of involvement. They had significant numbers of inflammatory nodules. Abscesses is typical for a hidradenitis suppurativa trial. But if you look from left to right and you look at this individual in the clinical trial, the 1 goes to 0. And the draining tunnels goes to 0 as well, too. And all that we see left really at the upper portion of this photo is maybe some PI or post-inflammatory erythema, maybe some hyperpigmentation, but complete resolution of these deep-seated inflammatory changes that we see in these patients. And, this is the individual typical of the way that the protocol in the trial was set up in the 320 milligrams every 2 weeks, the first 16 weeks, and then, of course, crossing over to every 4 weeks thereafter. Let's move forward. So we can see sustained results to really up to a year. It's really nice to see what happens in 2 weeks, and I think that's great with this condition. But we ought to be able to have some predictive information that we can actually say to our patients when we're first counseling them, this is the pattern you're going to see. You have a pretty dramatic early improvement in the first 2 weeks, first few months, with another reason why there's slow but progressive improvement in these patients with that bump that we're talking about in the first 2 weeks. And we see continued climbing of improvement over time. But this is a really good example that patients that we are treating, as long as there are no particular consequences of the therapeutic or side effects, you got to continue therapy. We see over a 20% capture rate between week 16 and out to just about a year at week 48, where 81% of the subjects that crossed over from the control period to the open label extension having a hidradenitis clinical response score of 50 or greater at about 81%. What is also striking is reproducible data. And I just don't mean, data, let's say, from 2 trials. This is pooled data, which is why we're looking at numerically and not so much statistically. But striking to me is if you look at week 16 and you see those individuals that crossover and go into a 320 milligram subcutaneous BIMZELX every 2 weeks, they catch up very quickly. We can say there are patients, even if you look in that next 16 weeks, look at the significant incline, those individuals that are able to achieve at least 50% improvement of their overall appearance and clinical response over this 16-week time point once they're randomized to receive the investigational product, and they continue to improve over time at 320 milligrams every 2 weeks. Now, that's observed cases and pooled data. Now, if we were to raise the bar a little bit, Because in longer term data, as we get closer to a year, and then even after that, most clinical trial data is as observed or observed cases. But if we were to look at the HiSCR 50 response, and we were to kind of change the statistical analysis and make it a little bit more challenging, like we talked about potential protocol deviations or individuals that were given a protocol prohibited medication inadvertently or needed rescue therapy, more important, as we see here, the numbers don't significantly drop. These patients will have pretty profoundly effective responses. We see those individuals at the end of 16 weeks that were receiving IP or investigational product with BIMZELX from week 0 all the way to week 16. Still, we're pretty close to that 60%. And then we get additional capture over time. And again, the placebo group, when they cross over, gets significant improvement with a significant delta of over 20% between week 16 and week 48. So the statistical analysis doesn't not necessarily matter very, very much, but this is just an example of making it more stringent. Next slide. And some patients over time, remember when we look at that 81%, when we look at that pooled observed cases a couple of moments ago, and we see it again here, in that milieu, remember when someone's 81% of the subjects are at HiSCR 50, that's at minimum. And there are others that exceeded this to achieving HiSCR 75, 90, and 100. Let's click again. And so we see the numbers in individuals that got 75% improvement or 90% improvement or 100% improvement. As I mentioned earlier on, close to 30% of these subjects by the end of a year were able to completely clear their HS. Let's go backwards a little bit and look at the control period. We saw that data from before, that close to 60% of the subjects at that still very high bar of HiSCR 50, but 41% get 75% improvement. 23% get 90% improvement and 17% just in that first 4 months. We don't give up on therapeutics that are helping our patients, even if seemingly they get an initial response and there's slight leveling, but you see that the responses climb over time. Moreover, if we even specify specifically what happens to the actual active abscesses and nodules, the mean reduction from baseline in the inflammatory lesion count at week 58 was 3/4 of the subjects. And if we look at the group in a different way, and we look at what percentage of individuals had no new draining tunnels, which is critical for these patients, it was 90% of the patients had no new draining tunnels at week 48. And so this is very promising, not only the data that we see it in the control period, but we want to be able to say to our patients, what do things look like at the end of pretty much close to a year, as we see here in week 48. Now, individuals that may have flared, as we see here, flares were a secondary endpoint, and flaring was somewhere around a 25% loss of response and 25% of increase in those active nodules, inflammatory nodules, and abscesses over time. As a general commentary, 82% of patients who were on bimekizumab, BIMZELX 320 milligrams every 2 weeks with a crossover to every 4 weeks dosing, 82% had no flares over the course of that first year. And then we see the percentages to the left of those individuals in that first 16 weeks that may have had some flaring. And we see it actually very similar regardless of the dosing regimen. You'll remember, even though we had it blocked out, that there was an every 4-week dosing regimen, and that first 16 weeks did not reach the primary endpoint of HiSCR 50. So back to another subject, 2 things going on here. To the left, what you basically see here is an individual from the clinical trial with pretty profound upper inner thigh and inguinal HS with significant inflammatory nodules and abscesses, a total of 5, no draining tunnels. And here's an example of an individual that is framed here who is a young woman who's 23 years old, suffering with HS. As the years have passed, I progressively got more bumps and abscesses anywhere where my skin met itself, like in my inner thighs, as in the example that you see to the left here. And that's an actual clinical trial patient. Let's do one more click. And you can see from baseline with the AN count of 5 with no draining tunnels, and you have a reduction by 4 in the active nodule count and the abscess count. And remember, with the high score, you can't get an increase even of 1, if you will, from your baseline, because you're considered really a non-responder where the selection and the designation of the high score is concerned. So profound improvement here. You see the significant improvement in that inflammatory burden, and really only mostly a little bit of post-inflammatory change. Let's continue. So it's really nice to see the clinical improvement. It's nice to see the improvement in the inflammatory changes that we just saw in some clinical photos. But how did the patients feel? What did they all feel like through their lenses? In terms of pain is one example here. So more than 90% of the patients report in general that pain interferes with their quality of life, even to some degree, more so than even the clinical appearance of these horrific lesions. And so this is what I was referencing before, a numeric rating score for pain. This is the HSSQ that assesses the skin pain severity. And so you can see 0 up to 1 is none, from 1 to 4 is mild, from 4 to 8 is moderate, and from 8 up through 10 is severe pain. And these scoring systems, which is a pain response score, is also inclusive, not just of the pain, but that collaboration that we talked before about pain, itch, smell or odor, and the drainage and the oozing. Because if you think about Hurley scores, for instance, they're visual, but they don't quantify how these patients feel. So what happened? Let's divide up the individuals in terms of their skin pain by those criteria that I just mentioned. And let's just look at the individuals who at the beginning were somewhere between 0 and 3, and just what happened over time. Now, you couldn't be lower than a 3 in terms of your pain to be in this trial. And if we look at baseline in terms of those individuals who had more to the mild side of their pain, and then we looked at week 16, typical, the dosing regimen for the trial, and then week 48, we have 50% of subjects only having either no or mild pain in that 0 to 3 range, and then close to 2/3 with either no or a little bit of pain over time, over the period of 1 year. So we would say 3 times as many patients reported none or mild pain through that first 48 weeks. Moreover, if we look to those individuals like the woman that I described to you, who couldn't sit down in my clinic when she was considering a clinical trial, if we look at those with moderate to severe pain scores 4 through 10, and we look at 81% of them at baseline, then at week 16, 50%. And then it plummets down to 36%. And so there's significant reduction with 2 times less patients reporting moderate to severe pain at the end of that 48-week period. And so we have significant improvement, whether there's more of that mild pain and those patients improve. If they're 3s, they may go to 2 and then to 1 and or to 0, as we're seeing to the left. And then those that are in more severe pain get significant improvement over time. Now, BIMZELX is the first and only approved therapy that actually measures what's called the high squall. And that's a hidradenitis specific tool. It was validated by our colleague, Dr. Jocelyn Kirby, published a number of years ago in the British Journal. And it is specific to this disease state. And it's similar to the dermatology life quality index that we're used to, but it really covers the impact on quality of life in 3 parameters. The symptoms that we just talked about a couple of moments ago in the HSSQ, but then we combine it with the psychological impact, depression, embarrassment, anxiety, concentration, sexual desire, and then impairment of activities of daily living like walking, exercising, sleeping, sexual activity, bathing, putting on clothing, working, and even what one has as a choice for what they wear. And then there's point systems that's divided up, and the total score is between 0 and 68. And this really very nicely demonstrates that impact, not just so much on symptoms, but also the overall impact on quality of life. Very nice to have this validated scoring system. So what happened? What happened in terms of the improvement because of the impact of this condition on quality of life? Well, we saw improved quality of life responses really as early as week 16, and it was sustained through week 48. So if you look at these ranges, as we looked at the numbers on the previous slide, all the way up to 68, and we look at those categories of mild, moderate, severe, and even very severe, these patients at baseline were all right at that bottom component of very severe. So these individuals had significant pain and significant impact on their quality of life. 7-point reduction just in the first 4 weeks, a 10-point reduction by week 16, and we see the continued improvement over time by half in terms of the improvement of quality of life by the end of week 48. Let's keep going. So it's nice to see that something works, but what about the safety profile? And I think it's a general commentary. If we were to look at the data for the safety, whether it's the control period or the open label extension, long-term extension, up through 1 year, and we look at the data in percentages, and we look at it per 100 patient years as we look at this data, the safety profile of BIMZELX in the HS trial was actually very similar to what we saw in the psoriasis trials, with upper respiratory tract infections, headaches, injection site reactions, some tinea infections, gastroenteritis, some herpes simplex infections, folliculitis, and even some fatigue. So actually some components that we maybe even inspect in populations of patients with hidradenitis suppurativa. The majority of the treatment emergent adverse events with BIMZELX were mild to moderate, and they improved over time, and they did not lead to treatment discontinuation. It was generally very well tolerated. There have been no specific contraindications with this therapy, and there are no boxed warnings with BIMZELX. And we'll tease into the data a little bit more, the safety data a little bit more carefully. Next. So if we look at suicidal ideation and behavior, which has been a call out for individuals in the clinical trial, I have to share with you that I did a little bit of my own research, and patients with HS are 2 times more likely to have background suicidal ideation and behavior as a general commentary. During the 16-week control period of the BHERD-1 trial and BHERD-2 trial, there were higher rates of SIB that were reported in those BIMZELX treatment groups. With that said, even per the FDA, no causal association has been made between therapeutic and that particular behavior, the SIB, and there were 2 attempted suicides in subjects who had a prior history of neuropsychiatric disturbances. Now, what are the clinical implications? Well, first of all, if you look at the top, short-term and long-term, and we look at these data points and percentages, first of all, in the population in the first 16 weeks, it's 0.2% versus 0 in placebo. Just as a general comment, and in reference to what I said about the background rate in individuals who have HS, the numbers are low, and perhaps what one might expect in the population of patients with hidradenitis suppurativa. And we really don't see a heightening of any signals for SIB in more long-term data. So I think we have to weigh risk and benefit. We have to counsel our patients accordingly. And I will also share that the bar has been raised in some of these newer generation clinical trials where the Columbia Suicide Severity Rating Score was utilized, which is a very, very kind of high bar, challenging scoring system for measuring suicidal ideation and behaviors. There is a call out for liver function abnormalities, as we see here, upwards of 5 times top normal. But what's interesting to me, if you look in the short-term control period, we see equally, essentially higher numbers of liver function abnormalities in population of these patients in the clinical trials. Again, another call out for this disease state where we do see patients having background metabolic associated fatty liver disease. And so we might expect that even patients that are not on a biologic therapy may in fact have some background liver function abnormality. We don't see an overt safety signal even long-term as we see out to the right. And again, I think the most important thing here is a counseling point. We have seen liver function abnormalities across many inflammatory skin disease clinical trials, including psoriasis and psoriatic arthritis and other HS trials too. And so I think the clinical implications are as follows. Counsel our patients, make sure that they're aware. We do our baseline labs that we normally do. And if in your judgment, you think someone may have some clinical manifestations of some liver abnormality, we would hold therapy and repeat some laboratory studies. But it's not a specific regimented requirement of this particular therapeutic. Next. In terms of the overall safety overview and the outcomes through 1 year and out to 2 years, the majority of treatment emergent adverse events, some of the other conditions that we're concerned about, like malignancies, other hepatic events, IBD, the rates generally are low over the course of 1 year. We don't see new safety signals over time. And I think the biggest call out is really for cases of candidiasis in general, which run overall in about that 20% range, which of about 15% of those cases are oral candidiasis. Now, that is a specific call out where we have to counsel our patients that in general, when you inhibit IL-17, which is a mucosal protective cytokine, IL-17 in and of itself, that you might get some cases of candidiasis, and we do see it here. Theoretically, and just me talking here, is it because of that profound targeted inhibition of IL-17 FF? I don't know that we know that, even mechanistically, but nevertheless, this is a counseling point for your patients. A lot of this that we've alluded to already, we know that HS, the patients on BIMZELX are adults who have moderate to severe HS. We've gone over the discussion point of SIB. Any biologic therapy may have an inflammatory inhibition of inflammatory cytokines that may result in infectious processes, as we've alluded to already, as with all biologic therapies. And as we saw in the psoriasis clinical trial data, we have to screen our patients for tuberculosis. And so we're doing quantiferon golds or TB spots, or maybe some of you are doing PPDs. Next slide. We've gone over the concept that there was some slight elevations in some liver function tests. And so we do these as screenings at baseline with most of our patients going on biologic therapies, and we'll do them here. I alluded to the fact that, like other biologic therapies, that there was no exclusion for inflammatory bowel disease to enter into this clinical trials, much like the psoriasis trials as well. And I'll call this out here. It's very important. Cases of inflammatory bowel disease have been reported with IL-17 inhibitors in general, including BIMZELX. And so we would avoid the use of BIMZELX in someone with active inflammatory bowel disease. And during BIMZELX treatment, monitor the patients for any signs and symptoms of IBD and discontinue if there's new onset or worsening signs and symptoms. You know, we see background rates of inflammatory bowel disease in patients with HS. That is not insignificant in that population. And just these are counseling points for our patients. And the interesting thing is that it just says avoid the use of BIMZELX in patients with active IBD. Just interesting in reading through that. Live vaccines should not be administered during any immunomodulatory therapy. And so we need to make sure we get those age-appropriate vaccines ahead of time before initiating BIMZELX, particularly those live vaccines. And the most common adverse events overall in the plaque psoriasis and hidradenitis suppurativa trials were URIs, oral candidiasis, as I alluded to a couple moments ago, headaches, injection site reactions, tinea, gastroenteritis, HSV, and the others that I alluded to previously. Next. The dosing, next please. As we alluded to from the clinical trials, it is one dose, which is 160 milligram subcutaneous doses. It's available in a 1 cc prefilled syringe and a 1 millimeter auto-injector. Again, every 2 weeks for the first 16 weeks, a little different than psoriasis, and then one dose or 2 injections of 160 milligrams every 4 weeks thereafter. You know, it's fantastic to see that we have a new therapeutic in our toolbox. It is profoundly effective. The safety profile looks good. And I think it's important to say that very much consistent with what we saw in the psoriasis trial. But if you can't get it, what good is that for our patients? And so what we have with the BIMZELX Navigate program, which we're used to, this helps makes the treatment journey smooth for starting our patients with this drug. They can get it rapidly. It's affordable. There's one point of contact. With commercially insured individuals, as low as $5 per dose of BIMZELX and $15 per dose while insurance coverage is pending. And at least for me, my representatives have been very giving with samples to get these patients started because we really don't want them suffering. There are nurse ambassadors, which are a single point of contact, and then you're all used to, at least now after this past year with our experience in our adult patients with plaque psoriasis, the MyNavigate patient portal and saving cards that are available to our patients accordingly. And certainly you want to get with your UCB representative. So what do we achieve with BIMZELX? How can we raise those expectations and really meet those expectations and those goals that I talked about before so that patients can see, they can feel, and they can live this difference and improve their overall quality of life in terms of having moderate severe HS. Rapid response, we saw this as early as week 2 with those 22% of subjects achieving high score 50 in that very short time point. High levels of efficacy just beyond high score 50, 75, 90, and 100. Remember, close to 30% of the subjects achieving that very high bar at the end of week 48. Sustained control over time, improvement of abscesses and inflammatory nodules, nose draining tunnels out to 1 year. The pain reduction significantly observed by 3 times an increase in the number of patients reporting just minimal or no pain by week 48. And don't forget those individuals at baseline, that 81% of them had in that more, moderate to severe pain at baseline, and then plummeting down to just above 30% of those individuals. And so significant improvement in pain, improvement of quality of life, as we saw improvement of those HISQOL, those HS quality of life scores, and of course, a consistent safety profile. So with that, I am finished. If there's any questions, I'm happy to to really address any particular questions you may have. Of course, that those need to be on-label questions. I would just close by saying our patients with hidradenitis suppurativa are fortunate to have new therapeutics in the toolbox like BIMZELX, bimekizumab. And thank you so much to UCB for delivering this product to market, and as well to the SDPA for giving me the opportunity to share this data with you.